Our next speaker for the evening is Dr. Sudiel M Jan. Can I have his CV, please? But I can just say extempore about Dr. Jain, that he's such a wonderful person and he has the Total Hormone Institute at Indore. He's doing incredible work at his institute. So here we have it. So he's done his DM endocrinology from Pijmer in Chandigarh in 1995. He's a consultant endocrinologist, and his institute is something that it's an envy for everybody, and everybody should visit it once to see what an ideal clinic should look like. So I have had the pleasure to go to his clinic and see it. And he's key faculty for CME at various meetings. He's been part of a lot of international trials, some of them being leaders, Savotimi, Canvas, Emparec, Verify, Carolina, and he has contributed immensely to literature in diabetes. He's also authored a book, How to Get Most Out of Your Pump. So today we have the pleasure to hear him about modern sulfonylureas, trusted companion of past, present, and future. The stage is yours, Sunil. Thank you.
Thank you, Dr. Sanjay, for the kind words. And let me share my slides. That is modern sulfonylurea, the past, present, and future. And I'm talking this just after SGLT2 inhibitor talk and lot of things because being discussed about what should be done with sulfonylurea now. So let me give you a quick review of the sulfonylurea's past and my expectation about their future. This is what is the sulfonylurea compound being. So they have in common this sulfonylurea structure. And then both sides, this aryl and R2 group keeps changing, and that's how we have different types of sulfonylurea. And why this is pertinent to know, because we are going to differentiate between conventional sulfonylurea and modern sulfonylurea. So whether it is conventional or modern, this sulfonyl component remains as a common in both, and the difference is on the both sides of the groups, which make them different. If we go back to the past, in fact, these are the age-old drugs being used even before metformin for the treatment of diabetes. And we know the 1942s and those eras when some animal trials of the sulfonamide class of drug with name 2254RP was found to have some hypoglycemia. And similarly, cases of typhoid fever in France in Montpellier, when they were treated with this sulfonamide, these people had hypoglycemia. So they tried to find out what's responsible for that, and that's how somehow accidentally sulfonylurea class was discovered. So this is the brief past history, and then like we saw with insulin, what was in 1921 and what are the options today. Similarly, in sulfonylurea, we started with the basic compound like tolbutamide, chlorpropamide, and now we have reached to the modern sulfonylurea like glimepiride and gliclazide. And these are the three major concerns which has been always talked about sulfonylurea. And this I am talking of the era when we were predominantly using conventional sulfonylurea. The major issue was the hypoglycemia and weight gain. The CV safety component was added later because say around 15-20 years ago, when we were not talking of this cardiovascular safety data. The CV safety issue became important after 2007-8 due to post-rosiglitazone story. Otherwise, nobody was talking about the cardiovascular benefit of the drugs, and that's how we are now into a different world. So if we look at the weight gain and hypoglycemia concerns, they were more often seen with our older generations of sulfonylurea. So let me just touch upon the generations of sulfonylurea. This is just by convention now, that's how we are defining it. First generation, few will talk first, second, third generation, or many will tell it just first and second generation. So first generation sulfonylurea, those who are very senior in diabetes practice, they have the experience of using these drugs like chlorpropamide and tolbutamide. When I was doing my MBBS MD, those days chlorpropamide was still available, but remaining were disappeared. So they have now history. All the second generation sulfonylurea, that is glipizide, glibenclamide, and gliclazide, and then third generation glimepiride are available to us. But if we go from their effect point of view, I think the better way of classifying sulfonylurea can be the older generation sulfonylurea and modern sulfonylurea. And in the older generation sulfonylurea, we have still glibenclamide and glipizide we are using. And we know that glibenclamide is a drug which is quite potent in terms of insulin secretion, and hence it causes more number of hypoglycemias and obviously weight gain, because these two adverse effects are interlinked. And then we have now the modern sulfonylurea like gliclazide and glimepiride. So when we talk about modern sulfonylurea like gliclazide and glimepiride, the risk of hypoglycemia and weight gain is far less as compared to the older generation of sulfonylurea. So these sulfonylureas, which are now newer generation, they are working on beta cells in a little different way. Their binding affinity, their tissue penetration at beta cell level is such that they are not unnecessarily stimulating insulin at those quantities which glibenclamide like drugs used to do. So that's how already one big change has happened when it comes to sulfonylurea. Many things still talked about sulfonylurea may not belong to modern sulfonylurea. They may be true for drugs like glibenclamide, but it is not true for the modern sulfonylurea like glimepiride and like gliclazide. Now, modern sulfonylurea, now let me focus on the modern sulfonylurea. Take an example, glimepiride. What is the effect on weight gain? And now we used to talk in past about a lot of weight gain with sulfonylurea and a lot of hypoglycemia with sulfonylurea. But now we have recently quite big randomized double-blinded trial, which are definitely to a great extent in favor of modern sulfonylurea like glimepiride. So let us quickly review on the effect on weight gain. What is the risk of hypoglycemia if we compare modern sulfonylurea versus the older generation sulfonylurea? And whenever we talk of cardiovascular safety, the connection of sulfonylurea is not with heart failure like the pioglitazone was. The connection of sulfonylurea is with the issue what we call as ischemic preconditioning. So what happens to the ischemic preconditioning with modern sulfonylurea and how it differs from the older generation sulfonylurea like glibenclamide? So these sulfonylureas which are modern, they have a quicker attachment and an earlier detachment. Their tissue penetration is such at beta cell they are causing stimulation of insulin secretion, but they are not continuously stimulating the receptors. So more of a closer to a physiological stimulation. That's how they differ at the receptor level. And we can compare the hypoglycemia of glibenclamide versus glipizide versus gliclazide versus glimepiride, the all four sulfonylureas we have. And we can clearly see here that the older generation sulfonylurea like glibenclamide has quite high incidence of hypoglycemia as compared to glimepiride or gliclazide or glipizide. So the risk of hypoglycemia, when we talk about, we cannot compare glimepiride same as glibenclamide. There is a huge difference because of the pharmacokinetics and receptor binding potential of glibenclamide and glimepiride is entirely different. When it comes to ischemic preconditioning, now here this is an interesting study which is comparing the effect of glibenclamide versus glimepiride and placebo on ST segment shifts during balloon inflammation in percutaneous transluminal coronary angioplasty. And this has been an article which has been published, say, around 20 years ago. And here you can see that the major effect was of glibenclamide. Glimepiride was as good as placebo. But these are the short studies, and similar kind of many studies which we have, which had shown earlier that glimepiride is not interfering into ischemic preconditioning and not causing any bad cardiovascular outcome. And thus we have so many kind of studies here. I am not going to discuss these studies one by one. It will be too boring for all of us. So these all studies in general have given a favorable evidence, because since these modern sulfonylureas are available, so look at all these data. And the story started from UGDP study in 1970s, when the tolbutamide is a sulfonylurea, when it was compared with insulin therapy. In those days of 1970s, when this study was done, obviously it was not planned the way current cardiovascular outcome studies are planned. But in these studies, it was shown that there was increased or a bad cardiovascular outcome in the tolbutamide group. And since then, because of this particular study, to all the sulfonylurea molecule, referring to this study, US FDA has always kept a warning of cardiovascular safety on sulfonylurea. Those days, these modern sulfonylurea were not available. Even in the UK PDS trial, only glibenclamide was used. So whatever data we had were with the older generation sulfonylurea to these big, well-known, famous trials. And then we had the modern sulfonylurea trials, in which I would like to label particularly advanced trial, where gliclazide in a sustained release formulation was used. Tosca IT trial, where glimepiride was compared with pioglitazone, and the trial which I am going to discuss in more detail, that is Carolina trial. In all these trials, which are of a big number, done in a proper way, we could not find any big or any kind of bad cardiovascular outcome with sulfonylurea. We all understand that sulfonylurea are very useful drugs. We understand that like insulin is also a very useful drug, but can cause hypoglycemia. Similarly, if judiciously used in a right manner, sulfonylurea can be a good choice. But there had been always a concern for sulfonylurea, because they work on potassium channels. They work on potassium channels of beta cells, close them, and thus cause insulin secretion. And there had been always a concern, because these potassium channels during ischemia, which are lying in the cardiovascular tissue, must open, and that's how ischemic preconditioning will happen. So if sulfonylureas are closing the potassium channel as beta cell as well as a heart, then how they can be cardiovascular safe? So that has been always a matter of debate, which was solved only after this Carolina trial, which I'll discuss after a few slides. So that's how this UGDP trial with tolbutamide had raised a concern, and looking to sulfonylurea mechanism of action of potassium channel blocking effect on beta cell, this concern was genuine, and that's how there was a warning on sulfonylurea because of the mode of action. And in mode of action, it is possible that sulfonylurea may not be safe for the cardiovascular tissue. But during a long period, we did not have any big data or in a double-blind randomized manner. So let us come now to the point of sulfonylurea cardiovascular safety. Now we are specifically talking to the modern sulfonylurea. That means when we compare glimepiride or gliclazide, what is the information with us? Let me again do a recap of ischemic preconditioning, and the importance of ischemic preconditioning is to reduce the necrotic tissue area, because during ischemia in cardiovascular tissue, potassium channel will open, And opening of this potassium channel causes vasodilatation. And in addition, it also reduces the cardiac workload. And these together will lead to a reduction in the necrotic area. That's how is the ischemic preconditioning will have a good effect. And for that matter, in cardiomyocytes, there are mitochondrial potassium channels, which are the most likely effector of this ischemic preconditioning. This is known so far. And that's what you can see in this image. If there is no ischemic preconditioning, the necrotic tissue area will be big. If there is a ischemic preconditioning, the necrotic tissue area will be small. And it has been a hypothesis that being a potassium channel blocker, sulfonylurea will go into cardiomyocytes, and there they may abolish ischemic preconditioning, and that's how they can result in a large infarction area, and that finally will translate into a bad cardiovascular outcome. But is it true? It looks hypothesis, but is this hypothesis true? Does the sulfonylurea, and when I'm talking of modern sulfonylurea, does these modern sulfonylurea interfere in ischemic preconditioning? So here we will have to differentiate between modern sulfonylurea and conventional sulfonylurea and their effects. These are the data which are basically retrospective data collected from those patients who are receiving sulfonylurea, and these are huge numbers. Thousands of the patients, their data are collected, and they're just trying to see what is the relative risk. So you can see here that glimepiride and gliclazide was having a lower relative risk of cardiovascular events. So overall cardiovascular mortality wise, in various different trial data, we can see here again, this is a huge number of different trials. And then this meta-analysis also did not show any big increase in all-cause mortality or CV mortality or myocardial infarction or stroke. This is glimepiride, which is associated with reduced mortality rate in diabetes with coronary artery disease, where again, glimepiride, glipizide, and glyburide, these three sulfonylurea were compared. These are again retrospective data where those patients who are receiving different sulfonylurea, they are now followed up, and what is the cardiovascular event number is happening, they were counted upon, and that's how this information is created. This is the well-known TOSCA-IT trial where metformin with sulfonylurea, metformin versus glitazone was compared, and here we can see again it's comparable. P-value is not significant. So, but here the issue is we talk both about we are talking now about pioglitazone versus glimepiride. So more important, if we want to settle this issue, we were earlier doing the way I'm talking about with some retrospective data, but now fortunately we have a cardiovascular outcome trial on sulfonylurea. And we have a CVOT now that is on glimepiride. Because these are age-old molecules, who will do a CVOT on them? But fortunately, glimepiride was selected in Carolina trial cardiovascular CVOT study, which was a head-to-head comparison with linagliptin. Generally, in a cardiovascular outcome trial, whatever you see, all cardiovascular outcome trials, one group is drug and other group is placebo. I feel that most likely Boehringer Ingelheim have thought that let us take linagliptin in a cardiovascular trial and comparator to be kept as a placebo. Rather than placebo, let us keep comparator as a glimepiride. And it might have been assumed because of the potassium channel story that very likely glimepiride group will have more cardiovascular events, and that's how the number will be even higher than you will compare with the placebo. And that's how in this cardiovascular outcome trial, you see on one arm is glimepiride and on one arm is linagliptin. So by chance, now we got a very good data on one of the very useful and very often prescribed drug in India, that is glimepiride. This trial, 43 countries, more than 600 sites. And I am also one of the investigators. My center also participated in the Carolina trial. So we are also one among these 600 sites. And when we started this trial, obviously in any cardiovascular outcome trial, it is the number of events which matter. So we have to wait for those number of events to occur. Initially, this trial was planned for 4 years, but number of events did not happen, and it took 7 years to have those number of events. And that's how this trial lasted for 7 years. And in these trials, we took the patients who either had cardiovascular disease or had more than 2 cardiovascular risk factors. And that's how a large number of patients in these trials were our day-to-day clinical practice. And now we were looking for cardiovascular death. So 6,000 patients, double-blinded way, followed up now, either on glimepiride or linagliptin. And now we are following them with the standard care for the management of dyslipidemia and hypertension. And we are looking for now in these 2 arms, CV death, non-fatal MI, non-fatal stroke, hospitalization for heart failure and unstable angina. And that's how this trial was observed. And at the end of the 7 years, now we were for the data, and we know this terminology MACE, that is the 3-point MACE was the primary outcome, and then other things were thought of. And that's how this trial data were released. And to our surprise, the linagliptin and glimepiride were same when it comes to the primary outcome, that is the MACE. That is cardiovascular death, non-fatal MI, and non-fatal stroke. The behavior of linagliptin and glimepiride was found to be same, which you can see in this table. 356 events happened in linagliptin arm and 362 events happened in glimepiride arm, and you can now see cardiovascular death, non-fatal MI, non-fatal stroke. The difference between the 2 groups is statistically not significant. And if you read the top line, that is MACE, you can see the hazard ratio 0.98 means, and with a confidence interval of 0.84 to 1.14, that is on the both sides of spread is equal. That means they have exactly the same role on cardiovascular outcome, but there was one difference, that is weight gain around 1.5, 1.8 kg was higher in glimepiride arm versus linagliptin arm. And to our surprise, if you look, the glimepiride arm was having a stable weight, initial gain, and then rather there was a little loss, but there are no further weight gain. And we clinicians have to decide that you are around 1.5 kg weight gain over a period of 7 years, what significance you want to give to that. But yes, there was a weight gain, and obviously there will be more hypoglycemia. We understand it is a sulfonylurea. So now suddenly this is another issue. How CV glimepiride turned out to be sulfonyl cardiovascular safe? So then we came to know that cardiomyocytes have potassium channels, but they are of 2 types. One is a sarcolemmal potassium channel and mitochondrial potassium channel. In earlier tissue culture studies, it was shown that glimepirides bind to the cardiac potassium channels. But which potassium channel? Sarcolemmal. It is not binding to the mitochondrial potassium channel. And we know now that the mitochondrial potassium channel are responsible for ischemic preconditioning. And hence, glimepiride, since it is not binding on mitochondrial potassium channel, it is not interfering in ischemic preconditioning. And that's how you can see in 2021 ADA recommendation, and look at the cardiovascular safety and characteristic of sulfonylurea 2nd generation. That means they are talking about glimepiride because that is the only 2nd generation sulfonylurea is available in US. And this is the ADA table. You can see the effect is neutral. So modern sulfonylurea like glimepiride, they don't interfere in ischemic preconditioning. They can cause hypoglycemia, but it is less in number, and our judicious use is important there. And they may cause little weight gain or no weight gain, much weight gain. That's how It's not sulfonylurea. Now we should talk on modern sulfonylurea, which are definitely patient friendly, and that's how I have shown in this slide. And lastly, these modern sulfonylurea have shown a lot of benefits. In addition, they are cost effective. And one important thing we should see into this slide, that is what is happening. We keep talking that sulfonylurea are disappearing, or what should be the place for sulfonylurea. If we understand the pathophysiology type 2 diabetes well, I presume that future sulfonylurea will remain. You can't manage patients without sulfonylurea with their that long duration of history. And here is the evidence. These are the big world trials. And here we can see that in all these trials, more than 50% patients were on sulfonylurea background therapy. So my conclusions, sulfonylurea are used since decades and they will remain in use for decades. We understand both sides of them and we keep using them, but now modern sulfonylurea are more reassuring for us. So I conclude with the words that they have a good past record, used in large number presently, and will remain a choice in future. Thank you very much.
Thank you, Dr. Jain. I think it was a very good overall summary about sulfonylureas. It's always been a point of discussion in various meetings that are sulfonylureas are they going to stay, or they're going to be of the future, or they're going to be of the past? Considering the new molecules and the data that we have, and your lecture just told us that we are still going to use sulfonylureas for a long time to come, not only because of the cost factors involved in our treatment. So not only because of the fact that they're more cheap and affordable and people have experience with it, but also we still have a good data that they can be used. And you just showed us all the data that how good they are in use for, in our patients. I don't see any questions for you. So thank you very much for this wonderful lecture. And we hope to have you back again physically next year.
Thank you, Dr.
Thank you
Sanjay
so
and
much.
Dr. Neeta. Thank you. Goodbye.
Thank you so much.